Alaikum, Masal Khair. Good evening, everybody. My name is Ibrahim Sbeih. I'm a neurosurgeon, and we are transmitting live from the Farah General Hospital here in Amman, Jordan. The backdrop is this street in Jerash city, which is second only to Rome in terms of the artifacts and the ruins there. This is daytime, and this is early nighttime with some of the performances there. This is in Jerash Festival, which happens every year for the last 40 years. The topic for today is the radiation-induced tumors, and we are going to present two cases where tumors developed and induced by the gamma knife use. When I was preparing this lecture, I did not know the amount of information that I need to pass. At the end of the day, it was a huge task to do. So I'm going to divide this lecture into two parts. First part today, and the next part will be next week. So, radiation-induced tumors can happen after conventional radiotherapy or after radiosurgery. So let's speak about radiation. There is evidence, a lot of evidence, over the last 100 years that convincingly linked radiation to the development of cancers in humans. This is undisputed, this is well-known fact. Let's go back to the origins. Röntgen, back in 1895, discovered the X-rays. It was the accidental discovery, actually, and he got the Nobel Prize for it. The director of his lab, Ibrahim, who's Armenian, he was the head of the department of the lab there. He had some problems. His fingers were amputated, and he died of cancer. And that's because of exposure to the radiation. Thomas Edison, the famous American inventor, who discovered so many things, again dealt with these X-rays, and he lost his vision. And his assistant, who's the next picture, he had amputation of his arm, and he died of cancer. And when Thomas Edison was asked about X-ray, he said, "Don't talk to me about X-rays, I'm afraid of them." Back in 1927, Joseph Muller was the first German scientist to say that X-ray exposure leads to genetic mutation and thereby can cause cancer. This was the first recognition of this. And then came the atomic bomb on Hiroshima and Nagasaki. As you know, this happened in 1945. On August 6, Hiroshima was hit. 3 days later, on the August 9, Nagasaki was hit. These are the still pictures that were taken from the aeroplane which had dropped the atomic bomb. People would say, why 6 and 9? Well, not on the same day. Hiroshima was decided first, so they hit it. 3 days later, they wanted to hit Yokohama, but there were clouds, so they were asked to go back home. And as they were going back home, in the middle of the clouds, they could see Nagasaki, so they hit Nagasaki. This is the airplane that took the first bomb. It's called the Enola Gay, and it is named after a lady who is the mother of the pilot. And the first bomb was called Little Boy. The second bomb on Nagasaki was called the Fat Man. The pilots who took the first airplane, Paul Tibbett and Charles Sweeney, who actually flew the second airplane. Let's see the video.
Skin cancer.
Sure. So many. And just to give the terms that X-rays are good, but Again, we have to be careful. Yes. This video is without sound, and it is so impressive because the story is speaking for itself. Again, this is the pilot. This is B-29 bombers, and this is the actual footage that was taken from the airplane as it left the scene. This is the footage of Hiroshima. This is the epicenter where the bomb actually was dropped. So where exactly the bomb, if you visit Hiroshima, you will see this building still standing there. This is the epicenter where the bomb was dropped. I think 170 people died instantly. And these are the victims of the bomb. The birds and things. Even then, they could not realize the magnitude of the problem. When Paul Tibbett, the pilot, was asked about the morality of this, of course, this is not a trial for America or trial. Why did they do the bomb? Are they with it or against it? It's not the time or the place for it. But when this man, the pilot, was asked about this bomb, he said, the morality of this. The morality of dropping that bomb is not my business. I am a bomber pilot who was instructed to perform a military mission. So he did not feel any guilt about it. Yet, when he died, he did not ask to be put in a bomb. He asked to be cremated and his ash to be thrown in the sea because he was afraid of the revenge of people. So it played on his conscience. So there has been since large cohort of patients who survived the bombs. Not all people died. The people at the epicenter died, but the people just outside the city, they survived the atomic bomb. So there was a lot of papers on these people developing brain tumors. Here they are. They started appearing late. There is a reason for this. Hiroshima 1945, and the first paper to appear was 96. Because people did not want to know about it. So this paper, Incidence of Intracranial Meningiomas in Nagasaki Atomic Bomb Survivors. Please.
We're talking about it is the latent period between the exposure of radiation and the
course.
development of solid tumors.
Of course.
Maybe lymphomas and leukemias, it takes 3 to 5 years.
True.
But solid tumors need 5 to 20 years.
Yes, but
depending on the
we are
type.
talking here about 50 years. Period, which is, yes, between 45 and the first paper to appear was 96. 41 years actually, which has a reason, and it was a political reason. Another paper, 99, again about the high incidence of meningiomas among the Hiroshima atomic bomb survivors. The third paper in Japan, 2002, tumors of the nervous system and the pituitary gland associated with atomic bomb radiation exposure. 2004, clinical and epidemiological characteristic of first primary tumors of the central nervous system related organs among atomic bomb survivors. So this is a review of literature, the cases that has been reported. So it is a fact that radiation can cause problems. What happens with this radiation? It says the DNA reacts like anything else to the ionizing radiation as it would to another toxic agents. If you have a high dose of single breaks in the DNA, then this is easy to repair, but if you have 40 double-strand breaks, then this will cause cell death. So radiation will cause cell death where the dose is high, or it can cause some changes in the DNA which can be repaired or misrepaired according to the situation. So we are talking about these people. Then came this very famous landmark by William Kahan from New York, who in 48 in the Cancer Journal reported 11 cases of sarcoma arising in an irradiated bone. So he irradiated bone for whatever pathology, and he found that they developed sarcomas. Look at this.
There was an concept to use it in ankylosing spondylitis.
Ankylosing spondylitis,
Yeah, so
TB,
yes.
arthritis, etc., etc. So Kahan said, let's put the criteria. When and where should we say that radiation caused the tumor? So he said, we will put these criteria, and it's called from the Kahan criteria. 1. Tumor should be arising in the previously irradiated field. If you irradiated the arm, so the tumor that is going to develop is going to be in the arm, not in the foot. Number 2, there was no tumor in the foot or in the arm before the treatment. There was just one condition that was treated. You hit it with radiation, you develop another tumor. 3, that this tumor that you developed should be histologically different from the one you initially treated. Number 4, there should be elapsed time. You cannot give radiation now and then after 1 week you say this is caused by radiation. He said at least we need at least 5 years. Why 5? I don't know. And then the last one, that this person should not have a genetic or a predisposing condition for malignancy. So what are these conditions that they have predisposition to malignancy? NF1, NF2, von Hippel-Lindau disease, Gorlin syndrome, Fornini syndrome, retinoblastoma. All these are people who have genetic predisposition to cancer. So he says don't include this if he develops another tumor. And they classify the radiation according to be high or medium or low, but there is average latency, and this can be around 19 years. And then came this another landmark paper, and this is from Haifa, Israel, where they describe radiation-induced intracranial meningiomas. They said this: a lot of young children, Israeli children, were in the concentration camps. When they came to the Promised Land, Palestine, they were treated for tinea capitis by radiation, infrared radiation. And then later on, 30, 40 years later, they developed tumors. So there got to be some relation between the infrared radiation, which is very, very low, 1 gray, half a gray. And this is the recent infrared machines. Another paper from Israel, Tel Aviv, 1984, radiation-induced cerebral meningioma, a recognizable entity. They looked at the tumors, they described them very well. 88, another landmark paper by Ron and Modan, and they said tumors of the brain and nervous system after radiotherapy in childhood. They described these people, 10,000, 11,000 child who had low dose radiation for tinea capitis, and they developed tumors. Another paper by Walak, Israel, 98 tumors. Tumors in people who are 40 or 50 years of age, who, when he was a child, he received the infrared treatment for the tinea capitis of his scalp. Another paper by Mitch Berger. Mitch is considered to be the world leader in glioma surgery, and this is the paper they published about these tumors developing in pediatric patients. Another paper from Israel, Sadetsky, about 253 patients developed meningioma after radiation for tinea capitis. There was time between the exposure and the tumor, 12 to 49 years, 50 years. So when somebody presents a paper and say gamma knife does not cause tumors, when he has just given it 3 or 4 years ago, it is not correct. 2008, radiation-induced meningioma by my friend Felix Szymanski. He's a very famous skull-based surgeon, and he described these radiation-induced meningioma because these are induced by radiation. Look at this. And when they happen due to radiation, they are very ugly. Grade 2 or grade 3, invasive, very, very ugly, and they cause alopecia and loss of hair. 2004, intracranial meningioma developing at low interval following low dose, 1 gray or half a gray, and they describe the patients. Childhood intracranial meningiomas after high dose, so it can happen low dose or high dose, and there is always latency period. These are the papers published, the authors, and the number of patients. And then came this paper, intracranial meningiomas following irradiation, a growing problem. It is a growing problem from Bristol in UK. Again, the cases that has been published. Why am I putting this? It's to convince you that this is not my personal views about it. This is the international literature about it. So it is confirmed. I'm just passing it to you. Radiotherapy-induced second cancer. Are we doing enough to protect young patients? Malignant transformation and the new primary tumors. In benign lesions, they have treated benign lesions. The thing is this, we used to think that radiation is given for cancer. Of course not. People are treating benign lesions with radiation. So this is the reason. Young patient with benign lesion, you treat him with radiation, think twice about it. 98, Dalton, in this paper, malignancies in patients treated with childhood for acute leukemia, mean period is so-and-so. So there is always a latency of people. And then this paper by Osama al-Mufti from Little Rock, Arkansas, about 16 patients of his who developed another tumor due to radiation. Of course, Osama al-Mufti does not like radiation, like myself. This is leukemia after 1.5 years of age. Look at this, developing this cavernous sinus meningioma. And he described this monosomy of chromosomes 1, 6, and 22. Monosomy. And, monosomy. So the chromosome becomes 1. This is the effect of radiation. I'm not saying that radiation is evil. Radiation is a good weapon against disease. But you have to use it properly. Nowadays, it is used haphazardly without any thought behind it. And he made a review of literature, putting all the cases that have been published about these people developing tumors. Ibrahim from UK, again he's a friend of mine, risk of second tumor after radiotherapy for pituitary. Pituitary adenomas, you removed some of them you give them radiation. 5 out of about 300 patients developed another tumor with a latency. 2006, Mayer, again, he described this in acoustic neuroma. There has been malignant change. 2009, 143 patients, radiation-induced meningioma. Malignant transformation of vestibular schwannoma after fractionated radiotherapy. Review of literature. So, we're thinking about radiation as treatment, but what about X-ray? Simple X-ray or CT. This can cause cancer. And why I'm mentioning this? Because this is taken lightly by the nurses, by the young doctors, by even the senior people. بتشوفهم برضه بغرفة الأشعة صور أشوف اللي يصير يعني بتصور مرة مرتين ثلاثة مش صار شيء. Nothing's gonna happen there and then. Something's gonna happen later on. For you as a nurse or a doctor to be in the room where X-ray is taken for a chest X-ray or for putting a screw in the spine or for whatever, you have to be away by 8 meters to escape the effect of radiation. And you have to have the Ibrahim, you have to have the thyroid collar. So we're doing this without thought about it. dental radiographs, variominimis, mammograms, angiograms, interventional radiology. Dr. Adam, you are here, Sheikh?
No.
The exposure of these people during interventional radiology is high. And one has to be careful about it. You mentioned that many times.
Of thyroid especially.
Exactly. But it does not mention, nobody does it. As if thyroid is not important. This is a very famous report, 2002, by the International Commission on Radiological Protection. What did they say? The absorbed dose to tissues from CT scan often exceed levels known to increase the probability of cancer. So across the board, in states, in England, here, the use of CT scan is done haphazardly without thought behind it. Look at this paper from USA. And published in the New England Journal of Medicine, they looked at the dental x-rays and the chest x-ray and mammogram, and they found the incidence of these tumors. Again, another paper, cancer risks from diagnostic radiology, chest x-ray, CT, mammogram, whatever. And dental. Also, we don't think that dental, this little beam that we take x-rays for our teeth, cause a problem. Dental radiography after age 25 years, fillings and tumors of the central nervous system. It can cause tumors of the central nervous system. And here are the tumors. This has been reported. Brain and salivary gland tumors related to dental. Salivary gland, brain, due to just dental use that we take. So don't take it lightly. Dental X-ray, 2004, and the problems that is associated. What about cellular phone? Until last week, the last time I looked at relationship between cellular phone and brain tumors was something like 12 years ago. And I could not find any paper. And I remember I had a TV interview, Jordan TV, direct question, does cellular phone can cause brain tumors? The answer is no. I have not come across any papers. Now, in preparation of this lecture, I found a tremendous change. Reports are increasing on the risk of meningiomas developing on the ipsilateral side of the phone, whether you hold the phone on your right ear or left ear. This is a very famous paper by Charles Steele, a friend of mine from Australia. He's an endoscopist. Cell phones and brain tumors. And this is a meta-analysis involving 11 studies. So it is serious. There is adequate epidemiological evidence to suggest a link between prolonged cell phone and development of ipsilateral tumors. And what kind of tumors? Acoustic neuromas, gliomas, and meningiomas. So be careful in the use of telephone. Tell your children, tell your members of the family, just to use the phone for good reasons. شو طاب خليهم شو لبستي شو رحت على الحفلة شو الفستان الأحمر والكلام الفاضي. They spend hours and hours talking nonsense. So these are the cases. I'm just passing this information to you, it's not mine. Cell phone and brain tumors. This is a cry from Ron Powell from Illinois. He's a neurosurgeon. He says, this needs data from the cell phone companies. It is time for action by the neurosurgical community. How far are you from the station, from the powerhouse of these telephones? How much time did you spend there so that they can put good data? So, I presented to you the radiation risks. And the lessons we learn from here is this. Radiation is not evil, but use it properly. So radiation, like cigarettes, is established carcinogen. Radiation is a treatment for cancer, but also is a cause for it. Exposure of the brain tissue to ionizing radiation is potentially carcinogenic. It will cause damage to the DNA, it will cause misrepair, and this will cause chromosomal mutations. And what is the effect on the brain? Brain atrophy, necrosis. We all hear of radiation necrosis. It can cause atrophy, necrosis, cognitive functions, loss of thought and memory and everything, visual loss of vision, loss of hearing, total loss of pituitary gland, vasculopathy closure, demyelination, calcification, bone marrow changes, and most importantly now we know that it can cause tumors, including cancers. Again, radiotherapy is a good tool. It is our defense against cancer, but to be used properly. That's why I'm against the policy where people would take a little bit of the tumor, called biopsy, and then send patients for radiation, right? We have seen it so many times in practice in Jordan, because people do not bother to work. They will take this biopsy and send the patient with no result. It's going to be useless, because radiation effect depends on the volume that you treat. Send big volumes for radiation, is going to be failure. Back to Kahan. This is mine. This is, I just put it. For 70 years, November 48, Kahan put his idea to establish the relationship between radiation and the tumor. I'm saying it is time to change. This is a 70-year-old study. It is not a Bible, it is not Quran, it's not anything. We can actually look at it and criticize it. Why 5 years? Who decided it's 5 years? Why not 6 months? And he excluded that if you have a genetic disease that should be excluded. Why should you exclude that? Because if you want to develop if you are going to develop a tumor, you are going to develop it. So radiation-induced neoplasm after conventional radiotherapy is well documented and realized. But what about radiosurgery? Let's see. So we finished with relationship between radiation and tumors. Let's see radiosurgery. It's called radiosurgery or stereotactic radiosurgery or gamma stereotactic radiosurgery. This is a term that was coined by Lars Laxell in Sweden, where I visited and stayed there for 6 months. What is the definition of this? Delivery, please read with me carefully, delivery of a single high dose. So the difference between radiotherapy and radiosurgery, radiotherapy is called fractionated. You give 45 degrees fractionated over 6 weeks. Every day, every other day, you give a small fraction. In radiosurgery, you give the whole dose once. You may give up to 7 degrees. In trigeminal neuralgia, they give 90 degrees in one single session. So it is single, it is high dose, but what? To a small and critically located intracranial volume. So not any case on the surface or easily approachable. Lars Laxell, the founder, the inventor, said don't use it except for those cases where you cannot reach. They are deeply seated, and then you can use it. The whole thing has been distorted into commercial business. The whole thing is forgotten completely. If you look, and I looked today, actually today, this afternoon, I looked at the Electa Gamma Knife Society website. And this is, I quote from their website. Gamma knife involves no scalpel or incision. Hooray, hooray. We're not going to do surgery for you. In fact, it is not a knife at all. He's telling you it is not a knife. Yet, people are still using the word knife to give the impression that they are surgeons. They are not surgeons. They have nothing to do with surgery. Yet they keep the word gamma knife radiosurgery. And this is dangerous. Can be used to replace. They want this to replace brain surgery and brain radiotherapy. They are against surgeons, they are against radiotherapists. They want all the cases to be sent to them because of money and nothing else. Lars Laxell, in Electa company in Stockholm, he produced the first treatment back in 1978. The next machine was in Buenos Aires, 1981. The third machine was in Sheffield, UK, 84. Pittsburgh followed, 86. And Charles, Virginia, 87. So it's rather young. This gamma is rather young. And we followed. I went to Stockholm. I stayed there for 6 months for training for gamma knife. And we brought it back 1996. This is myself treating the first case with vestibular schwannoma. We did not want to be behind. We want to be abreast of these developments. But I always put the statement here. a fool with a tool is still a fool. It is a tool. You use it properly, like radiotherapy, like a knife, like bipolar. And the models of gamma knife, starting with model U, which was the prime type, Jordan produced model B, then followed by model C, then followed by Perfection, 2007, it's called Perfection, and then followed by the new machine called Icon. Very nice names. What's the difference between radiotherapy and radiosurgery? Radiotherapy, you treat a field. So if this is a tumor, you treat the field in which the tumor is. So everything in this field will receive the same dose. That's why you fractionate it, because you don't want the brain here to be damaged. So 50 grays, you divide it on 6 weeks. Here, you give the radiation exactly around the lesion. In the center here, you may have 25 grays. In the periphery here, you have 10. And if you go out, it's going to be a very rapid fall down, so that here you may have 1 gray. So this is the acclaimed advantage of radiosurgery over radiotherapy. We don't treat everything, we treat just the tumor. We kill the tumor inside, at the periphery we give a small lesion so that we don't damage the brain. Very beautiful concept, but let's see. This is the machine, you put a frame. Nowadays you may not put a frame, and you put the patient in the machine itself. And the beams, 201 beams coming from 201 slots. Nowadays I think it became 192, and this is the Perfection, or the Icon. And what does this? It is just like in radiation. It is ionizing radiation, like all the other radiations. It will knock 1 electrons out of the orbit of the atom bomb. From non-ionized, they turn the cell into ionized, and they will cause breakage of the bonds between the DNA helix. This is the effect of radiation. This needs 2 to 3 years to be achieved. 2 to 3 years to be achieved. To have the effect of gamma knife in treating these tumors, to keep them the same size or smaller, you need 2 to 3 years. And in AVM, you need 3 to 4 years. But everybody soon realized that radiosurgery has limitations. It is not the promised aid that they promised. You have limitation of size. You cannot use it in tumors more than 3 centimeters in diameter. Now, they are treating 7 centimeter diameter tumors. The thing is lost completely in the commercial field of medicine. You have to be away from the optic apparatus by 0.5 centimeter at least. Now they are treating tumors like craniofaryngoma stuck to the optic apparatus. You have to remember that there's late recurrence, and if you need to go for surgery, if gamma knife fails, the man like the tumor continue to increase in size, then surgery is a hell of a difficult. And I'm telling you from the point of practice, I have operated on gamma radiated tumors, and they are very hell to operate upon. And we discovered that they also can cause malignancy.
And another major limitation is burying the evidence, of course.
You don't know what you're
Logically,
taking, of course.
what's the
They don't take biopsy to say that this is, say, whatever tumor and you want. They don't. They just want you to send the patient and, oh, this is meningioma, and hit it without any thought. Cortical meningioma, they treat it with gamma knife. Last lecture said, small tumor, deeply seated. So, and they say, oh, don't worry. Tumors induced by radiosurgery are very low. Don't worry, this is not radiotherapy. And you ask why? They said, oh, listen, we give small radiated volume. Small volume, 5 cubic centimeter, 10 cubic centimeters. Not like radiotherapy, they give 30. So we are better than they are. Second, that we use high single dose. And remember, this high single dose leads to cell death and not change in the chromosomes. Rubbish. It turned out to be absolute rubbish. Why? Because they found, like in radiotherapy, that 1 gray can cause tumors. It is impossible to make an accurate assessment. The problem is there, but we cannot really hold it completely. Why? Because all the papers that praise gamma knife have a short follow-up. Oh, we have treated 100 patients for the last 3 years and no tumors. Nonsense, rubbish. 3 years is not enough. Radiation-induced tumors happen 30, 40, 50 years after. So it is underreported, it is underestimated, and it is by intention. The gamma knife centers do not put their results on board for us to know. They estimate that this is the word. Should we use radiation-induced or radiation-associated? Oh, it is not induced. Come on, stop using this. Don't blame the radiosurgery for the tumor. When you say radiation-induced, you are sure that the tumor was caused by, no, forget it. Use the radiation-associated. This was the argument the gamma knife users put. The estimated risk of a second tumor after radiosurgery range from 0.1 to 2%, depending on whether or not you are advocate or opponent. So they say, when you speak about gamma knife, you are opponent. We who love and advocate gamma knife, we will put the risk as very low. Roberto Heroes from the States, he was reporting, and this appeared in New England Journal of Medicine, 1990. He was commenting on one AVM that was treated by radiosurgery. He said, oh, I have to give this word of warning. There is always a source of concern when radiation is used to treat benign conditions with a prolonged survival because radiation-induced tumors usually occur many long years after. This was the first cry from Roberto Heroes in the States, telling us, wait, don't be heavy about it. And then some papers appeared. 2001, radiosurgery-induced brain tumors caused by radiosurgery, by gamma knife in particular. I put those cases caused by gamma knife. I did not put cases caused by cyper knife or by LINAC. I just put this radiosurgery by gamma knife. AVM, and look at the tumor here. Malignant. 81 months. You turn this benign into malignancy. If this is my brother or my mother, I would kill the person who did it. A glioblastoma in a patient treated with gamma knife surgery. Vestibular schwannoma, how much? 8 months. And then develop this tumor. He would say, oh, we should not put it according to Kahan criteria. He said 5 years. I'm saying wrong. Kahan is not God. He put 5 years, but it can happen anytime. Malignancy in schwannomas, yes please.
يعني لما تكون 8 شهور انه ممكن تكون بدايتها كانت كانسر.
Sure. The argument goes both ways. Why did not they take a biopsy before? Second thing, that the strength of evidence saying, and I prove it, that it happens at the site of radiation. It happens at the site of the isodoses. I will put this later on. So all the defenses they built around them, around this practice, is absolutely falling like anything. So, malignancy, you treat what looked like to be a benign vestibular schwannoma, and then it turns to be malignant. This is not me, this is from UK, from Cambridge. Again, the review of literature and the cases. Like we said, these are the cases that did not have radiation, these are the cases that got radiation. So the people who say, okay, these people did not have radiation, yet they turned malignant, right? So this is argument can be used against us. Japan, 2002, Lancet, gamma knife, 6 years after gamma, malignant. So it's not my personal view that I'm telling you, these are the literature view. This is very important paper I would allude to many times. Second, tumors after radiosurgery. Is this the tip of the iceberg or bump in the road? The man is asking, Loeffler. He is an oncologist, radiologist, radiation oncologist. Say, Are these cases really caused by, or this is just something? He put the cases, but he immediately says, this is a bump in the road. Don't worry, people. This is nothing. 2004, this trio from Pittsburgh, they put this paper. They said, radiation-induced tumor can occur within the full dose or also on the very lows. The risk in stereotactic radiosurgery is less than radiotherapy. There is always a latency period. Long-term follow-up is advocated. But this is important. We don't need to change our practice. Forget about it. These are incidental cases very far in between. The evidence came again and again. 2005 from Japan, malignant progression of a benign tumor after gamma knife radiosurgery. It's not a coincidence. You treat something with gamma knife and it turns malignant. Come on. Radiation-induced tumor after gamma knife for arteriovenous malformation. This is where the arteriovenous malformation, and this is the malignant glioblastoma. Glioblastoma after stereotactic acoustic neuroma. You go for treatment of vestibular schwannoma, you develop JBM. Look at this. At the site of the low dose of the acidoses. Histological proven because they went in and excised it. Again, review of literature. 2007, and this is what I call denial. This is from William Friedman and Yansfield Florida. He's a radiation oncologist. He's telling you, listen, people, even when malignant tumors occur in a previously irradiated field, and even when they are meeting Kahan criteria, this may be coincidental. So shut up and sit down. This is not a problem. This is coincidental. Denial. They don't want to face the problem they have created. Evidence continues to flow. Malignant transformation of acoustic neuroma after gamma knife. Malignant. Malignant vestibular schwannoma. Review of literature. 2010, Sbeih journal by Yang. Case of high-grade undifferentiated sarcoma following stereotactic radiosurgery. What more evidence do you need? I can't say incidental, coincidental. We don't know the initial histology. Another paper, malignant vestibular schwannoma, Titon, or you call it whatever, caused by gamma knife. Review of literature. They have done this surgery. This is what left of the tumor. When they removed the tumor, it was benign. They gave it gamma knife. 7.5 years after gamma knife, it went berserk. They excised it, malignant.
That's the good.
It's all like this.
Yeah,
All,
this is
all these cases are like this. So what I'm saying is that they try to defend themselves by giving us so many evidence that this is not, this is coincidental, blah, blah, blah. But the evidence is flushing them away. 2010, radiation-induced rhabdomyosarcoma with this tumor that has been treated with gamma knife and rhabdomyosarcoma there. Histological proven. Review of literature. 2010. The risk of radiosurgery-induced tumors may be higher than previously reported. People started to realize, oh yes, maybe there is something true about this. The risk of radiosurgery is higher than previously reported. So it could be as high as 11.5%. And this is by Taddy and Howell, 2010. People are coming back to their senses. People are realizing the truth, in spite of all the evidence and I would say the lies that these gamma knife users use. 2011, malignancy in vestibular schwannoma after gamma knife. 9 patients of NF2, all received radiosurgery, all turned malignant. And this is by Mario Sanna from Italy, a famous neurotologist. There it is, NF2, there it is, malignant. Review of literature. All these cases, Mahmoud, are proven, histologically proven. 2000, yes, he is, neurotologist. 2011, by Schmidt, radiation-induced sarcoma in vestibular schwannoma following gamma knife. Huh? 7 months, malignant. So CAN criteria went out of the window for me. Review of literature. Radiation-induced malignant schwannoma arising from benign schwannoma after gamma knife. This at the time of treatment, and this is 6 years later, excised malignant. It's not coincidence. Review of literature. From Korea 2012, glioblastoma following radiosurgery for meningioma. This was a meningioma. Obviously, the surgeon is mediocre, and I hope he's listening to me now, because he did not remove the tumor. This is easy to remove tumor. He left this piece. That's what they usually do. Let's remove the major part, and we leave the other part, we'll give it radiation. Because this is a slowly growing tumor, it will take 10, 15 years to grow. This is a mediocre surgeon doing this, and I hope he hears me. They give it gamma knife, and look what is the result. Glioblastoma multiforme. Review of literature. And then John Regis from Marseille, France. I know him very well. I visited his unit in Marseille. In 2013, he said, listen, this paper, radiosurgery and carcinogenic risk, does not exist. There are no cases of malignancy in my series. And this is what I'm pointing. The gamma knife centers, they are hiding the true information. Intentionally or by design, I don't know, by design or by chance.
If you don't look enough, closely enough, and long enough, you won't see it.
Absolutely. 2013 from Japan, undifferentiated sarcoma of the cavernous sinus by gamma knife given for pituitary. This is the poor pituitary tumor, this is the radiation, this is the tumor developing. Again, review of literature. Radiation-induced meningioma after AVM. They treated gamma knife and then developed a tumor. From Minnesota, from Mayo Clinic. So these are big centers, respected ones. Secondary neoplasm after stereotactic radiosurgery, again from the States, 2013. All the literature review of how many cases, so many. From Greece, Sbeih put this paper, malignant schwannoma, and he compared with the time. Look, the time here, 90s, was less. It is increasing. And this is my point. The number of cases treated by gamma knife is increasing. So we're just seeing the early part of it. We will see flood of malignancies coming to us in very short period of time.
If I may, late effects of radiotherapy increase exponentially.
Absolutely.
So after a certain threshold, the incremental increase by year is not linear. It's
More than you.
it's logarithmic.
Yes.
It's exponential.
Update. Assessment of risk of radioactive induced neoplasm after radiosurgery. By Stark from Charles Street, Virginia, which is a famous center for radiation oncology, and he stated the cases that he found in literature. AVM, malignant tumors, histologically proven. You would say, oh, they should have taken biopsy from this. This is AVM. And the field where they treated it developed a tumor. So it goes without question, without even thinking. This is very sad. 4-year-old female, AVM, developed a glioblastoma after gamma knife. She died. And this is another patient with 6 years after gamma knife. Radiation-induced osteosarcoma after gamma knife. There it is. This is the doses. This is what I'm called isodoses. If the tumor develops here in the isodoses, you just cannot accept the fact. Now this is true. As I said, I'm not going to present my cases this time. We'll present it next week. And I will show you without a shred of doubt that the tumors developed in the isodoses of the treatment. And they say, oh, here is the high center. We will kill the tumor. Here is what? 4 days, 3 days. This is enough to cause tumor. Review of literature. Carroch, temporal lobe, gliosarcoma after treatment of vestibular schwannoma. Vestibular schwannoma and gliosarcoma. Histologically proven. Review of literature. Secondary brain neoplasm after gamma knife for metastasis. So you are treating metastasis, which is malignant tumor, and you cause another malignant tumor, which is disastrous. This is metastasis they treated with gamma knife, and they develop this JVM. Afterwards, 6 years. And these are the review of literature. A glioblastoma, this is the latest, 2019. This is the...
Can I ask a question, please?
Yes.
Why is the glioblastoma always?
Not glioblastoma,
Most cases, yeah, they are-
malignant vestibular schwannoma, malignant meningioma.
سؤال
Or-
معتبر.
Yes.
يعني هو عادة what developed from radiation is
That's
the
my
high
point.
grade tumors, glioblastoma, carcinosarcoma,
Sarcoma,
osteosarcoma,
exactly.
more sarcoma.
Sure.
Even I have a case report of a glottic sarcoma.
Sure.
Glottic sarcoma after radiotherapy, this is a case presentation, you can Google it.
The
It's
commonest
very-
tumor after radiation is meningioma. It is non-fact. Yeah.
All these tumors are very well known to be associated with radiotherapy, be they meningiomas, gliomas,
Glioma.
hybrid gliomas, sarcomas. They're quite one of the cancers that are very well known association with
Yes.
radiotherapy.
So this is a meningioma. Why should you treat it with gamma knife? Why? I have no idea, except that you are a mediocre surgeon. You cannot operate, so you go for radiation, pushing buttons, and then get the money, and call yourself a radiosurgeon. Glioblastoma. Review of literature. All these cases, I gathered it for you. From 98 till now, all the cases. Benign tumor changing into malignant. Benign tumor, another benign tumor. Malignant tumor, another benign. Malignant tumor, another malignant. So these are cases, and I'm keeping them on the screen so that if any one of you want to have a copy of this by his camera, he can go back and check that this is true. Look at this. And I have not included all the cases of radiosurgery. I just included the gamma knife. And this is the last case we described. So, what is the lessons we learn from this journey? Malignant transformation of benign second benign to a primary lesion. This is the classification. Malignant, position of benign. Second benign over a primary benign. Second malignant over a primary benign. Second malignant over a primary malignant. So all these have been reported. Gamma pre-treatment diagnosis must be confirmed. This is my recommendation. This I've been asking for all my life. You cannot treat by radiation without histological verification. Don't tell me the strength of evidence of radiology is meningioma. How many cases we have seen as meningioma and they tend to be sarcoidosis? The risk of radiation-induced neoplasm after radiosurgery may not be markedly different than that following radiotherapy. Now people are realizing that they are the same. This is by Stark and Sheehan in 2013. The risk of developing a secondary neoplasm after fractionating radiotherapy is 1 to 3%. Radiosurgery has the same percentage. The potential risk of radiosurgery is real. It is not my imagination. It is not I am against the gamma knife. I'm a user of gamma knife. I cannot be against it. I think it's a good tool when it is used properly. But not put it in the hands of mediocre surgeons, because you will go and hit everything. If you have a hammer, everything becomes a nail. You have a hammer in your hand, nails. You just kick them because you don't know anything else. And this is very, very, very sad. Mark Blitzky from New York, he said, the question remains whether in young patients with resectable lesion, it is worth the risk of developing JVM after radiosurgery. If I am a young patient and I have vestibular schwannoma or meningioma, why should you kill me and give me glioblastoma? All the patients receiving radiosurgery should be informed about the risk of radiation-induced tumors. How many centers in the world would tell their patients that there is a risk of malignancy? Very, very few. And I went back into this publication from Pittsburgh, and they say now, this stage, after all the denials before, at our institution, all patients with who are undergoing radiotherapy or radiosurgery, they are told of the risk of developing a second tumor. So many reports are showing new tumors or malignant transformation in patients after gamma knife. We need long-term follow-up. Short follow-up, it does not mean anything. We will now see the surge of cases after the many years of gamma knife. This is the time, 2019, 2020, we will see a surge of malignancies caused by gamma radiation. And again, I will go back to Kahan. I'm very much critical for that. For 70 years, the medical community has used Kahan criteria to establish this relationship. I'm saying it is time to change. Why should we consider 5 years? Why not 2? Why not 1? Why not 6 months? And how do you ignore this huge bulk of evidence? And when he produced his criteria, he put it for radiotherapy, not for the radiosurgery. And they are totally different kettle of fish. The risk of malignancy following radiosurgery cannot be ignored, especially that more than 1 million cases have been treated. So far, 1 million. So you will soon get tens and thousands of cases developing tumors. But look at this, and why I'm saying that long follow-up is needed. Until 2010, only 300,000. In this very short period, 9 years, 700,000. So this, we don't know anything about. And they will come back to us. Absolutely, it's easy. So the number of reported cases of radiation, it's already increasing, and we expect to see further major increase in the future. So I go back to the Ruflar paper. He said initially, is this a palm in the road or tip of the iceberg? I say this is only the tip of the iceberg. We are just seeing the little tip of the iceberg. We will see the whole thing in a very short period of time. And I thank you. Any questions, any comments, please?
I find it surprising that anybody is surprised with what has been presented, because it's well known that radiotherapy and chemotherapy can cause late cancers. Cancer survivorship is one of the topics that are really close to my heart. The only modality that does not have second malignancy inherent in it is surgery. Chemotherapy can cause late malignancies. The fact that one has a first malignancy is a risk for another malignancy. And radiotherapy can cause late malignancies, be that stereotactic or otherwise. And the risk of late cancers with radiotherapy tend to be late. And after development of it, it increases exponentially with no blunting or there's no shoulder of the curve. Just keeps creeping up. And if you've heard any of my lectures on late side effects or complications of Hodgkin's lymphoma survivors or lymphoma survivors, etc., where we had the opportunity of observing them for decades after the end of their chemotherapy and radiotherapy, 15 years after the cure of a patient of Hodgkin's lymphoma, they start dying of late side effects more than they die of the original malignancy. And those are related to their chemotherapy and radiotherapy. And the rate of increase with radiotherapy increases exponentially with them. So I cannot really emphasize this enough. I'm really surprised that anybody would be surprised with what we're presenting today. So not explaining this to the patient is a problem. Not having a histological proof of the baseline lesion before exposing it to radiotherapy or chemotherapy, of course, for that matter, is a problem. And it's a problem that we continue to face on a daily basis.
This was Dr. Ala Haddasi, oncologist, hematologist. Any comment, Dr.
Yeah,
Can you come here because of the camera, please?
You said something interesting. You said you started gamma knife in Jordan.
Yes.
What is your experience? How many cases you did? And what's the follow-up? And what's the prognosis in that patient that you show in that picture, famous picture?
Can I leave this to the next lecture? Otherwise I'll be disclosing the secrets. So next time we'll be presenting the actual cases and we'll speak about that. Any questions? Sora?
بأنك تعترض على تسمية جاما نايف، ما هو الترم الرشيد الذي تختاره لهذه المعالجة؟
Exactly.
هذا واحد.
Gamma knife is stereotactic radiosurgery. Gamma knife is stereotactic radiotherapy. There's no surgery.
السؤال الثاني، عرضت في بداية حديثك 3 أو 4 معالجات ذكرها أو سجلها إسرائيليون. أحدهما كانت عن التينيا.
تينيا كابيتس.
هل هو جرب العدد الكبير على أطفال فلسطينيين؟ وغامر بذلك؟
Of course he did not. Dr. Sora is asking that some of the papers I mentioned from Israel about the patients with tinea capitis who were in the concentration camps as youngsters who went back to Israel and were treated with the infrared light. I discovered the same myself in the Palestinian children living in the refugee camps after the 1948 war. I have seen those patients as adults with massive tumors. So
This
it
was
is
the standard at that time to treat tinea capitis.
Exactly.
Yeah, it's
Yes.
not. And also spondylitis, TB, but it's
Absolutely.
now obsolete.
It's not an issue.
It's no more.
yes.
Yeah.
Please.
Did you mention any case or did you see any case of lymphoma after
No, I did not. But next time I'll mention gamma knife causing tumors.
Sir, you keep saying the radiation is a tool and it's a good tool and it's a weapon, but we should use it properly. Yes. So I want to ask you if there is a guideline. You and Dr. Bilal, if you provide us when to use it properly, okay? So that.
Mahmoud,
we'll deal with it,
you know the answer. You are asking us for me to repeat, so I'll repeat it.
Yes.
With my friend. The practice of taking a biopsy of a tumor for the therapy is to be condemned.
Yes.
It is a crime against humanity which is practiced every day in Jordan.
Yes. But
Also, you know, in GBM,
yeah.
the survival depends on the extent of surgery.
Yes.
We saw cases of GBM treated with the gold surgery, gross total resections, and we have a 5 and 7 year survival of GBM. I have a patient who recurred after GBM and has been treated for the second time with surgery and with the radiation to a total dose, accumulated dose of 100 gray, and he lives after recurrence 2 years. And this is not.
Yes.
This is
what I'm asking. In case of benign tumor, pituitary invading the cavernous sinus. What is the guideline? Is it to wait and see or give the patient radiotherapy? Meningioma grade 2 and with the gross total resection. What to do? To give him immediate post-op radiotherapy or wait and see? Vestibular schwannoma after near total resection. What's the guideline? That's what I am asking about.
Again, you know the answers, but I will repeat them for you.
Yeah.
The guidelines are well known. For the malignant tumors, you have to remove 85 to 90% of the tumor. If you can't, don't.
Yes.
Because radiotherapy is going to be
We
useless.
teach that from you. Yes.
So malignancy is well known. Now
Yes.
for benign lesions, why should you go for a benign lesion with gamma knife when you can treat it with the surgery?
If there is residue. If
If
I
there is
can't
residue-
remove it
If
completely.
there is residual, again the landmarks and the framework is there. Don't give radiation immediately. Wait. Why? Because when you take much of the bulk of the tumor, you have decreased the blood supply, and that will cause the tumor to stop growing.
Yes.
So it is well known. The guidelines are there, but people do not want to follow them because it does not suit their capabilities, nor their thoughts, nor their training. We are in Jordan producing generation after generation of people who carry certificates to kill and not to treat patients, because we don't follow this. And the same we speak in the Arab world, the same we speak in the Muslim world, the same we speak in the underdeveloped world. I'm sorry to say that. And this is a fact. We have to rise and face it.
You know what's the
and
dilemma?
fight it.
You know what the dilemma?
No,
You kept saying that.
No.
But if there's another one who is, I know the truth, okay? But for another people, if there's another one who will sit instead of you, he will.
He's wrong and I'm right.
Yes.